So a little bit of housekeeping at the front, at the start. But I guess firstly to say welcome to this event. You're very welcome here. This is the second of 6 online events and 1 in-person event that's taking place this week that will make up our event series called Health Creation Coming of Age. And if you attended this morning's meeting, we hope you enjoyed it. And that little blip there was to remind me to tell you that this session is being recorded, and it will be available on the Health Creation Alliance YouTube page from around mid-November. And we're also going to be producing a short write-up from these sessions, and that will be made more widely available as well. We won't be taking verbal questions from people through the main part of the session, but do use the chat function to have conversations and to share your insights, to say who you are. So do put your details in the chat box and email address, whatever, and to ask questions. And we'll try and pick some of those up throughout. But we will have a breakout session towards the end, and that's an opportunity to have much more in-depth discussions. So we wanted to be able to make that available for people. So you can join the Health Creation Alliance. It's free, and you can play your part then in spreading and advancing health creation across systems, which is our mission. Please complete the evaluation form at the end of this session as well. As you log out, it will pop up. We'd be grateful if you could just give us some feedback. So I want to offer a big thank you to all our partners and sponsors who are supporting these events, including National Health Executive and Public Sector Executive, HLM Architects, NHS Property Services, Novartis, PPL, Solace, NHS South Central West, and our patron, Lord Victor Adeboale, and also Lord Nigel Crisp, who's a kind of umbrella figure for health creation. We are delighted to be working with our partners on this, who bring so much to the sessions, and without them it would not be possible to run the series of events that we wouldn't be having this stimulating, timely and informative series. So with that said, why coming of age? Why Health Creation Coming of Age? Well, for the last 7 years, the Health Creation Alliance has led a national movement for health creation to address health inequalities. And for the first 4.5 years, things moved slowly, but in the right direction. But of course, COVID has changed everything. COVID-19 is just one of many destructive forces in our world today. It exposed stark health inequalities, at the same time as making visible some of the more hidden aspects of how communities work, become resilient and thrive. It concentrated minds on how inequality leads to poor health outcomes, but also on how health inequalities can be addressed by creating the conditions for communities to become strong through connection. So for the last 2.5 years, it's been a very different experience for us. Health creation is experiencing something, what might be described as a coming of age. It is undergoing a metamorphosis, but there's a lot more maturing still to do. And health creation must become business as usual across our systems, alongside our efforts to treat illness and prevent ill health. So we do feel we're moving into a new phase where much broader partnerships and collaborations are becoming possible, and the collective mission must be to build back together, including with those communities who experience the poorest health outcomes, and to increase our efforts to make the necessary change happen. So we're having call to actions through this series. We're starting with a call to action, and that is for all integrated care systems to recognise health creation as equally important in addressing health inequalities as the treatment of illness and the prevention of ill health, and to adopt and embed it as a way of working to make it business as usual across the whole system. But of course, there are more things that need to be done. And so we will seek to identify further calls to action through this session and through the event series. So in this series, in this session today, what we're looking at is how health creation can be embedded at all levels of the system and from the ground up, where health creation happens within communities through our relationships with friends, family, schools and colleagues. And it also happens at the interaction of communities and frontline services. And at this point, Neil, I'm going to ask you to just share the slide of the health creation framework, because it needs to happen at that interface if we're to address the huge and growing burden of inequality that we know affects some cohorts disproportionately. So if you were at this morning's session, you would have had the long version of this slide, but this is the short version, because health creation is a process, and it's the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their own lives and immediate environment. And this is something that happens to all of us. But when this happens, our health and well-being is enhanced. Of course, professionals can get involved in this process, but only if they work as equal partners with local people, focusing on what matters to them and their communities. And that equal partnership is really important. And we've identified 6 features of health creating practices, and we identified them through talking to communities whose health had improved over a number of years. And we asked them what it was that made the biggest difference to their health and well-being. And this is what they told us. They told us it was listening and responding. It was truth-telling, which is the foundation for trust building. It was a focus on what they can do, not what they can't do. Self-organizing, helping, being enabled to connect, or let's say connected communities being able to do more and act. Power shifting, so some of those resources that communities are so starved of often being transferred and learning and that kind of thing. And reciprocity is the one that we've added within the last year or so. So this is why the Wigan deal is called the Wigan deal, because there's a deal going on. There needs to be reciprocity there, a give-get. And so that is how we have how we have defined and let's say distilled what it is that actually happens when health is being created, and how professionals can get involved in that. So what I'm really saying through this is that health creation happens at the hyperlocal level. It happens in the community and at the front line. If it doesn't happen in the community, it doesn't happen. So this session is exploring whether and how health creation can be a driver of transformation across whole systems from the ground up. We believe it can, and we're looking to explore that here today. And the Health Creation Alliance is currently working in Surrey Heartlands and Frimley ICS to support something of a wholesale shift to health creation as a way of working and transforming systems from the bottom up. So we'll see how we get on. But today we're going to explore all of this. We're starting with 4 speakers who are used to operating at different levels within what are now integrated care systems. So enough from me. I'm going to introduce the first speaker, who will speak for around 5 minutes, and that is Kirit Mistry, who is a community leader and, importantly, he's chair and founder of the South Asian Health Network. So there you are, Kirit.
Right, thank you. Thank you for the kind invitation for joining you today. Certainly what I'm going to be saying is coming from a South Asian context, but it's also true for marginalised communities who are actually experiencing similar challenges. So certainly from the community, the voices and what we're experiencing is, and it's not probably something that needs to be kept spelling out, is about lack of engagement from us. So South Asian Health Action was born as a patient care community-led charity because a number of lack of voices on various systems, lack of lived experience voices, helping to shape services from a culturally sensitive point of view. So if the first challenge is a lack of engagement, then leads to lack of involvement, lack of equity in resources. So we are kind of starved of resources because people and institutions want us to do things in goodwill, and that goodwill has run out. I keep saying that if you want to engage with us, you've got to value what we bring. So that's what we're experiencing from a community point of view. And finally, we've got to move away from 2 key elements. One is having this tick box mentality, right? You know, we've got a bespoke, from our communities, bespoke how you engage with us, bespoke how you involve us, but most importantly, our services have to be tailored to meet the needs of the communities you're trying to serve. And finally, please, plea is, right, you know, we are not hard to reach. It's some of the institutions that are hard to reach. So let's go away from the rhetoric of hard to reach, because the marginalized communities don't like that. And that's certainly from where I come from, South Asian communities, we're quite a large community. So, you know, everywhere, you know, I'm sure you can find an Indian restaurant. So how hard is that to reach? So I'm just kind of being a bit kind of, in terms of how do we address the, you know, okay, we've got these are the experiences, but how do we actually, you know, look at how you can involve us and the communities to play a part in what you're trying to do? Well, it's, you know, it's about engaging with us. It's looking at what we offer, so we can offer you that reach into the networks and the communities, the patients, the lived experiences in the population that you're trying to engage with. We can provide that culturally sensitive advice, information. In some cases, people may have language barriers. So it's about giving, you know, we can offer that language skill sets that you may need to help support that engagement. One of the key things is things have changed, you know, from 5 years ago when I set up this charity. We were kind of, you know, we've got the new system now, the integrated care boards, integrated care systems, the ICSs. You know, we had to actually, you know, I had to come and knock on various doors, and if the doors weren't opening, I'd kick them down, because I'd challenged them on 3 levels: on you know, looking at their websites and lack of diversity of presence, looking at their data in terms of, you know, how are they actually engaging from an equality point of view, and thirdly, it was about saying to them, well, you know, how can we work in a collaborative way? So it's good to see the Health Creation Alliance, their 3 Cs. I've kind of looked at it from another point of view in terms of, if you're going to be real to what you're trying to do, then be committed. You know, the second C for me is about, you know, co-production, you know, and co-design. You can't do it without us. And finally, you know, the connections. You can only drive what you're trying to do is through connecting with the communities, the patients, and most importantly, connecting with the faith organizations, because sometimes they're the largest institutions that are being missed out in terms of the health agenda. So I think it's important to not lose sight of that. And I think the final point, and this is where I'd like to kind of give credit to, obviously, the NHS England with their new health inequalities program, because we are seeing a real change in now health inequality is actually on the agenda, having more conversations. And I think that's kind of through the core 20+5. You know, it's just enabled us to go to our local NHS systems and say, look, there's this fantastic program. It's going to look at, you know, the core 20+5, but the most 5 clinical areas in our area. So, you know, cancer, hypertension, and respiratory. So these were the 3 areas that we knew that there were a lot of disparities, and it was just by talking.
Jessica dietitian.
Oops, and sorry. Can you? Hi.
Yeah, we can hear you okay.
Can you hear me? Sorry.
Yeah, we can
Sorry.
hear you. That's fine.
I was just going to say that finally, we now a delivery partner of our local NHS systems locally, delivering on that core 20+5, focusing with the South Asian communities particularly. But it's meant resources for us as a small charity to work in a collaboration and bring community connectors on board. So I'm going to, because of time, I'm happy to touch upon some of the questions later, but thank you for the kind invitation for being here today.
Thank you, Kirit. That's excellent. And it's clear that for you and the people that you work with, health creation sometimes looks like kicking the door down. So let's see if we can sort of improve on that collectively, I'm talking about. So we'll go on to our second speaker, Dr. Jill Orrow, who's a GP in Surrey Heartland. But Jill, you're so much more than that, and happy for you to introduce yourself in a broader way, and looking forward to hearing about your experience working at the neighbourhood level.
Thank you so much, Maren, for that introduction, and thank you for the opportunity to join you this afternoon.
And I just wanted to start by saying thank you to Kirit, because so much of what he just said there resonated really deeply with my experiences working in communities and neighbourhoods and systems over the past couple of years. So I am a GP by background, and I'm also the director of Growing Health Together, which is a place-based approach to prevention and health creation that's underway in East Surrey. I'm also other things, like a mother, I've been a carer, I've got other parts of my identity, but the one that I'm going to talk about today is the work in the neighbourhood levels through Growing Health Together. So in East Surrey, we've got 5 different primary care networks covering the major towns and surrounding areas. And for each of our PCNs, we've got a Growing Health Together colleague who is a primary care clinician who has a little bit of protected time each week to go out and connect with local people living in the neighbourhoods within their PCN footprint. And through this work, I've had the privilege of connecting with people in many different neighbourhoods in the Hawley area. And I think when I'm reflecting about what health creation has looked like in that journey, the first thing that really strikes me is how in the work in neighbourhoods, I'm showing up as myself, very much as my whole self, not as a doctor trying to fix people, not as a doctor trying to get people to change or to do something for me, but I'm just showing up as a fellow human being living in these just really extraordinary times, and somebody who deeply cares about the people and the places in our area. And I know that my colleagues who work in the other PCNs of East Surrey are showing up in their work in very similar ways. And I think what we've found reflecting with one another is that through that relationship first approach to our work, it's opened up huge potential and possibility to connect with a far greater diversity of people, organisations and groups than we have ever traditionally engaged with as primary care through patient participation groups, for example. And through creating these spaces where trust can develop at whatever pace is right in the circumstances, really just frankly magical things can happen. And in the very short period of time that I've got to talk to you this afternoon, I can't really reflect the abundance of health creating opportunities and initiatives that are coming forwards, but some of them include things like South Asian women setting up wellbeing groups for social connection, for joy, for physical activity, improving diet, through to African groups self-organizing and running fantastic arts events, literature events, and other health and well-being events in the area, through to women supporting one another with finances, with IT, with resources like clothes, bikes, you name it, it's being shared in a kind of circular economy in our area. I think there's just so much more that I'd love to share with you, but I don't have the time for. I've been asked to say a few words about what communities feel health creation looks like, and I wouldn't like to speak on really necessarily on behalf of the communities that we're working with, but some of the feedback that we've had is that people report feeling listened to, feeling valued, feeling a sense of belonging in their local community, a sense of meaning and purpose, a sense of joy, and how wonderful it is to be with other people that you can have a laugh with, as well as share your challenges with. And some people have reported really remarkable transformations in their physical and mental health and well-being, as well as things like reducing their alcohol intake, stopping smoking, and many other behavioural changes, which we haven't asked people to do, but simply through taking control and that mastery over their lives that Maren mentioned at the outset of this session. Through that kind of sense of control and confidence, people feel able to make the changes that they feel are going to improve their quality of life. And the benefits from the health creation work at neighbourhood level haven't really been limited to communities, but our colleagues, both within the NHS and within the wider sectors that we're engaging with, they have reported feeling a sense of rejuvenation, a greater sense of well-being, meaning and purpose, etc. And some people have told us it's helped them to stay in their role in the NHS at what is such a challenging time. But the work that has been possible at the neighbourhood level hasn't happened in a vacuum. It could only have been possible due to the listening and enablement with which we've been provided by our place and system leaders in Surrey Heartland's ICS. And the kind of behaviours that I've seen
Just one more
demonstrated,
minute.
thank you, by our system leaders have been that listening and that valuing of the importance of relationship building and integration. Not only integration at the system level and the place-based level, but also at the neighbourhood level, as is stressed in the fantastic Fuller's Stocktake, which was published recently. I think for health creation to work, there needs to be a shift of behaviour, power and resource, as Maren has said, right through the system, which ultimately listens to and recognises the primacy of action at a neighbourhood level, where health truly is created. And I think only if our systems can reorientate towards that, will we be able to make the huge challenges facing us right now in terms of population health, health equity, planetary health, and so many other areas. Thank you.
Thank you, Jill. And, you know, we'll be hearing a little bit more, I'm sure, about some of your work in the panel session. There's more opportunity to say that, but it's a delight to work with yourself and colleagues on that relationships first approach that you mentioned down in Surrey. So the next speaker I'm going to be introducing is Mike Barker, and he's going to be talking about the place level and sharing experiences of health creation and what that feels like, what Oldham is doing at the place level. And Mike Barker is the Oldham place lead there. So 5 minutes from you, Mike.
Thanks, Maren, and good afternoon to you all. Oldham's a part of Greater Manchester. In our area, we are trying to be relentlessly focused on creating conditions for residents to lead happy, healthy lives. Our way of working is about connecting economic ambition with reform public services and the well-being of people. So in effect, what we're really trying to achieve is a collective shift to a place-based system, very much focused on early intervention and prevention, moving away from organisational silos, building on assets and engaging communities. And what I want to share in the next few minutes are just a couple of examples of how that is being done. And before I do, I just want to say none of this is rocket science, and some of this is probably happening in lots of different places around the country. But to start with, we've got 5 primary care networks. We took time before the pandemic in doing some of the hard work of getting those boundaries of our PCNs aligned to our council district boundaries. And now we have 5 co-aligned natural communities in which elective officials and our general practitioners work hand in glove to plan services. We like to call them our network neighbourhoods. I'm sure other people got similar things. But before the pandemic started, these 5 collaborative partnerships were already working to develop different projects to support health and wellbeing, reflecting the interest, needs and the capabilities within each of the network neighbourhood. And whilst our whole community serves a population of about 240,000, the 5 distinct areas are very, very different and very, very distinct. Up in the east part of our borough, we have quite a large degree of affluence compared to the central parts of our town and town centre. So essentially, we're looking to establish a whole-scale prevention and early intervention system, bringing all of the health and care organisations together. And when I look to our west network neighbourhood, our local GPs are working with elected members to set up a variety of new community-led initiatives. Some of that's including support groups of parents who have additional needs. Some of it's about an English language group for non-native speakers. And some of it's just self-organised groups offering social connections alongside things like money advice, particularly in times of the cost of living crisis that we're currently in. In our East Network neighbourhood, focus is slightly different actually. It's about strengthening links with schools, and we've got a programme up and running there which helps to bring parents and pupils together with other parts of the community, looking at community running and fitness classes. That's having significant impacts on improving mental wellbeing. And in our central network neighbourhood, we've got Sport England working alongside us in a partnership to help establish a new kind of active travel infrastructure. It's really about walking and cycling, helping to reduce local air pollution and carbon emissions, whilst at the same time trying to drive up health outcomes and health benefits through physical activity. It's early days on that programme, but we're pretty optimistic. We hope to be able to launch that at scale across our borough early in 2023. Our central network neighbourhood is also quite popular for one of the community projects we've got up and running. We call it BAME Connect, and it's aimed to tackle social isolation and loneliness amongst those with Pakistani and Bangladeshi heritage in particular. And that is helping them to engage in meaningful activities and empowering to take proactive action. It was only about 4 days ago I sat in a room of 114 ladies from the Pakistani and Bangladeshi communities, all of whom have been trekking up Snowdonia, something they'd never envisaged they'd be able to do as individuals, let alone as a community. And the impact it's had on their confidence and their well-being has been absolutely phenomenal. During the pandemic, we've also learned an awful lot as well. We, in that particular area, knocked on 41,000 doors, had 80,000 conversations, and actually we transferred some of the responsibility for vaccinating our community to the community itself. I saw amazing people setting up pop-up clinics. We brought clinicians alongside them. They organised the logistics. They got the communities to come out and get the vaccination, and helped us to put together a programme to get people to understand what the vaccination was and wasn't in the face of some quite adverse media coverage. In the end, our rates were lower than Cambridge and Oxford, which is a pretty remarkable achievement. Perhaps the model or the jewel in our crown really is something we call focused care. It's the only service that we know of that's got a central aim of making invisible patients visible. And it's something that we're particularly proud of. It helps us to equip our local GPs to find the patients in most need and then help them access the most appropriate care via their primary care and, critically, the community health teams. Since we started that approach, we've realised that our workers not only support GP teams with the more anxiety-inducing complex cases, but our data also shows that patients with less are now having less unnecessary hospital attendances. There's less missed appointments and better access to relevant services. So, you know, from our point of view, I definitely believe that fostering relationships between statutory and non-statutory organisations and groups takes time, and it requires dedicated time, and it certainly requires funding. Bringing together community groups and public agencies through some form of partnership is absolutely critical. We like to do that through a neighbourhood board, and we have 5 of those operating each of our areas. It's not, though, enough for those working together to focus solely and only on the shared objective. There has to be more than that, we've found, and we believe that more is about values and trying to align values in communities to such that there is commonality of purpose. And all those involved really need to listen to what works, to be open-minded and to be curious, not to see it from a statutory agency only point of view. And then finally, for me, if we're serious about this, then we need leaders who empower and enable those who may benefit to actually start getting involved in creating the solutions for themselves, rather than sitting back and not being involved in things and having things done to them. So thank you, Merrin. We've learnt an awful lot over the last few years, and I'm sure we've got an awful lot more to do, and we're keen to learn from other places. Thank you.
Thank you, Mike. Good. Okay, so we'll be focusing. We've heard a lot about the need to listen, and I guess it's what you do with the listening, isn't it? So thank you for giving some sense of what this might look like at place level. And my 4th speaker is Professor Donna Hall, and you have lots of experience working at system level, both in the local authority and in an NHS Foundation Trust, Donna. And I think Donna really needs no introduction, so I'm going to just hand over to you and to offer a view about what this health creation might look like at the systems level, and then we'll go on to the panel session and look at the interconnections between these levels. So looking forward to hearing from you, Donna.
Thanks, Merrin. And just building on what other speakers have said, is it okay if I'm a bit controversial?
Absolutely.
So you asked me to throw down a challenge to people, and I suspect everyone on this call is kind of like-minded around the need to focus on prevention and build health creation in local communities. But I don't feel that is systematically being applied across all 42 integrated care systems, being honest. And I really do feel we need to challenge both NHS England and ICS leaders to be more radical. I think what we need is a bit of a context setting overview. And it's funny, I've just been on a call this morning with colleagues at New Local, which is a think tank that I chair, that I'll tell you a bit more about in the next time I speak, about the drive towards community power that we're pushing national politicians and ministers towards trying to anyway. And I think we've not really painted a picture that is sufficiently bleak to drive a compelling argument for the need to do something radically different. You know, do you remember the graph of doom about 12 years ago? There's a few colleagues nodding, but basically I think it was the Local Government Association did something that showed if we were to do nothing over the next 10 years, basically councils would have no money left and social care would be asset stripped. And the only things that we would really be able to provide properly would be a very scaled down children's social care offer and a very scaled down adult social care offer. And it's happened. Yeah, that's exactly what is happening now in local government. And yet what did we do to radically transform the way that councils worked with citizens? Very little, to be honest, Merrin, in my personal opinion. Some places did. I think Oldham tried to do some interesting stuff. We did in Wigan, which I was chief exec at the time. We can talk about that later on too. But really, we didn't radically transform things. We just went, oh yes. And we kept things largely the same. We didn't give our frontline teams, our frontline staff, that permission to innovate in a radical way. We didn't, we still had them going out assessing people repeatedly, referring people to other bits of the system and spending 80% of our time on assessment and referral, introducing new eligibility criteria whenever the funding got tighter. So we would tell people, I'm sorry, you're not ill enough or poor enough to access our services. The very restricted number of services that we hold here. The power is with us. We will assess you and refer you and go away, get worse. And when you're bad enough, you can come and access our limited menu of services. You know, I've had examples of an eating disorder service in Greater Manchester, where a mother came to me as the chair at Bolton Foundation Trust and said, this is what's happened to me. So basically, you know, her daughter was really rapidly losing weight and not eating, huge issues around her self-esteem and mental health and self-harm. She was told that her BMI was too high for her to access services. So she had to go away, get worse, with no help in the meantime, get worse, come back when her BMI was lower, and then she could access services. You know, that's the kind of scarcity public service model that we've developed in the last 40 years. And this is where we need a radical transformation. And I think ICSs have been set up with the right people around the table to make it happen. It's whether they've got the courage and whether they've got the permission to innovate and really radically shake up the whole public service offer that we've got across the 42 integrated care system. We're not going to get a workforce model from NHS England where a qualified and really experienced social care person is, you know, still paid £1 an hour less than a newly appointed healthcare assistant within a system. That's just, we're never going to get that system-wide change at NHS England level. Olivia might want to disagree with me later, but I suspect not. You know, so I think we've got to make it up, and we've really got to challenge, you know, and I know there's some work going on in Greater Manchester, but it's not radical enough. We don't pay we don't pay carers enough. It's as simple as that. They're going to Lidl and Aldi to get better paid jobs with less responsibility. I don't see anywhere doing anything radical. I think there's some good stuff going on in Leeds and Harrogate where they did supplement salaries, and they've created this new West Yorkshire and Harrogate Leeds Health and Care Academy, which is fantastic. So they're making care a career of choice. But, you know, there are 5 wards in my organisation where people are fit and well and medically optimised. They've just not got the care to go to. So, you know, Therese Coffey's, you know, crazy, ABC, whatever, is not going to be solved unless social care is resolved. And so we need to, I totally agree around leadership. Mike's absolutely right. Creating the conditions for leadership to be courageous, I think, is the challenge that we face across integrated care systems. Thanks, Merrin.
Thank you, Donna. Creating the conditions for leadership to be courageous. I've got it. Thank you, Donna. That was quite rousing, and you did indeed put a challenge out. And I guess the challenge now to everyone on this call is to fashion one or more calls to action for either ICSs or national government, or whichever part of the system, the greater system like you want. And this is the opportunity that we have, and that the Health Creation Alliance has created through this coming of age series of events. We think that health creation is coming of age in the sense that more people are getting it, more people are wanting for it, more people are talking about it. We've got 10 principles for working with people and communities that all ICSs have to do, etc., etc. But you're absolutely right, Donna, that it is not being applied in many ICSs, and you know, it is really worrying, this race to the bottom that we are seeing, or you know, have seen over the last 10 years, that you have to be, your health has to be poor enough to be able to get access to services. It's crazy, isn't it? And that is what health creation's about in many ways. It's about taking that control, communities taking control and being participants in health with services. And so we think there's a long way to go yet. We're just coming of age. There's a lot of maturing still to do. When I say we, I mean health creation is you know, just coming of age, really. But that's a huge challenge, and thank you, Donna, for that, because it is, you know, helped to sort of rocket propel this this event, I think, today. I don't know if anyone's got any, you know, before we go on to Olivia, who I think has arrived. I just wondered if anyone has got any sort of questions of each other from the speakers just now. And I'm afraid I haven't been keeping my eye on the chat box, but I'll just have a quick look just now. But I think that some of this will go, oh, look, lots of things here. So refreshing to hear this. Completely agree with Donna. Absolutely. Yeah, so there's more of that sort of comment than questions. But has anyone got anything to sort of just say briefly, or from the panel, and we'll wait till the breakout rooms for the bigger discussion. Kirit.
Yeah, thank you. I think Donna's presentation and all the presentations were great, but I think if we're going to try and get a consistent model across all the ICSs, I think we're going to be waiting for the next 20 years. We've seen the failures previously, so I think what we've got to start doing is looking at each ICS in its own right, and looking at what good practice we can glean from them, and looking at using that as a template to then work on others that are not doing well, because I think we're going to be waiting for long, ever and ever. So I think it's a great point, but consistency has always been an issue, and how we create our bespoke model for each ICS is to then look at working with Health Creation Alliance and others to make sure that's embedded across where they're not doing well.
Excellent. And these are some of the conversations that we can have in the panel session and the breakout sessions. So and what I'm going to do is move on to Olivia Butterworth now. And thank you, Olivia. I expect Olivia needs no introduction either. From the public participation team at NHS England. And in many ways, your team, Olivia, has been the author of these 10 principles. So we're looking forward to hearing from you about your ideas about whether you think that this is a way to shift the power and you know, support that ground up health creation.
Thanks so much, Maren. So Donna, I'm never going to disagree with you. I wouldn't dare. I would completely echo everything you said. So hi everybody, my name's Olivia Butterworth. I've been in post at NHS England in the same job, although my job title has changed 3 or 4 times. Leading on how the NHS involves people and communities, historically known as PPI or PPE. So we have an engagement community and a language that nobody actually understands. So how on earth are we ever going to engage anybody? And I'll just start by saying this, we have seen an improvement over the last 10 years, but the duty to involve patients and the public was introduced in 1972. So it was the year before I was born. And we really still pay lip service to it. And I hold true to that. I will continue to speak that truth, because unless we speak the truth and we continue to say everything's fine and look at this fantastic little project, we'll continue to fail people. So we have published new guidance. I am going to talk you very quickly through a few slides that relate to that guidance, but a few points I just want to make. And I know, Kirit, you mentioned hard to reach and this language and terminology. My challenge to colleagues working in the NHS and local government and the voluntary sector is who's hard to reach. Actually, it's the people who work in the system that are hard to reach. It's really easy to reach people who live in neighbourhoods and communities because you walk out there, you get on the bus, you go to where people are. They're not hard to reach. They might well be hiding from you because their experience of connecting with people in formal structures is usually really poor, and we've disenfranchised and let people down. So they have no trust in us. So why would they engage with us? My second point is about longevity. So I've lived in my current house for 23 years. I was a governor at my local primary school. I set up our before and after school club. And I have seen more community consultations go on in our village than I care to think about. They've all asked the same questions and they've all delivered absolutely nothing. Because new people come into post and they go, ta-da, we've got a great new idea. They pay no attention to the history of those communities. And the same is true of a lot of voluntary organisations. So this is about organisations rather than sectors. But we don't value the community histories and the community stories because people have really, really long memories. And once you've let people in a community down by not going back to them, by not being honest with them, it'll take decades to rebuild that trust. And people who work in organisations move jobs. They move jobs quite quickly, which is why I don't think this is sector specific. I think this is about all organisations. We need to recognise that. We need that longevity of relationship because we need to invest ourselves in those communities. So I've dropped a few links in the chat. The other thing I want to point people to is Cormac Russell's new book, The Connected Community. And it's really, really worth the read. And my challenge to Cormac around his asset-based community development approach, and my background is I'm a community development worker. That's where my heart lies. That's where my professional practice lies, is actually a lot of community-centered approaches really miss the people who society stigmatizes. They miss people who work in the sex industry. They miss people who are homeless. They miss people who are living in refuges because we don't want them in our backyard. So we have to be incredibly thoughtful, and we need really skilled practitioners to be able to host people and spaces with real kindness and humility and understanding, because people do experience racism, sexism, homophobia, transphobia, and so on from neighbours, from the people who live in the same communities as them. So the shift of power to communities, we also have to be mindful of those people whose communities really don't want them in their communities. And that requires a deep level of skill to be able to host those conversations and to make it really safe. So shifting to community approaches is the right thing to do, but we have to recognise that communities are often of geography and of interest. So people might identify with a community because of their characteristics as opposed to the geography that they live in, because that's safer for them. So if I can just share my screen really briefly, some of what I want to show you really resonates with what Donna was talking about. Oh, sorry, somebody just come off mute because I've got a horrible echo. No, it stopped, that's fine. So we've got a lovely flower. So Sherry Arnstein in the 60s produced the ladder of participation. The ladder implies a hierarchy in how we involve people. So we devalue consultation. Why? Consultation is a really, really valuable way to seek views, particularly when communities' views aren't all homogenous. They don't all think the same thing. So we need that consultative survey-based approach to be able to get views in from people. And we need co-production. But co-production is not the be all and end all, because if you have a co-production group, that requires people to invest time and energy. And if you're holding down 3 0-hour contract jobs and trying to keep your children fed, you ain't got time to rock up to a co-production group. We need many and multiple diverse ways for people to be involved without implying a hierarchy. So we've created a flower. It's not perfect, but there's we need to really value all of the different ways that we seek to involve people and really recognise the power balance that lies behind all of the ways that we involved. One of the biggest things that we don't do with people that we involve is we never contextualise and sense make what they've told us with them. So all too often we consult, we engage, we involve, we take that information away from people, and then we sense make it. Usually the white Oxbridge educated policymakers are sense making from what they've heard. And what they've heard will not necessarily be what people actually said. So we need to recognise that, and we need to recognise our own bias, and we need to involve the people in sense making. And that includes staff. Because again, what we tend to do is we involve the community over here, and then we expect the staff to do what the community have said. Without involving staff, we will fail to have the whole picture, because they are members of their community and they experience how hard it is to provide services and support for people. They also have ideas. So I'm going to share a few little pictures. They're not quite ready to share with you as images yet, but we're just waiting for some final tweaks. They've been developed for us by Anna Geyer, who's an amazing graphic illustrator. But this really does speak to what Donna described, which is our service model is set up to say no to people, particularly those people who have, we call them multiple and complex needs. Actually, they just have shit lives. Things have gone wrong for them, usually not of their making, but then the system punishes them. And we have this referral assessment process where people never actually get to having any help, and they drop out of the system, and then we call them hard to reach. And that's what we need to shift. So we need to shift that to starting with people. We need to really build on what's strong, not what's wrong. We need to think about, you know, the phrase "nothing about me without me" was coined in the 80s by the disability movement. We really need to embrace that, but also recognize there's a nothing about us without us. So groups of people who self-organize have a right to be involved. And a recognition that communities can do more when they do it for themselves, but without abdicating responsibility of professionals, because professionals have a role. And it's not, this is not an either or, should be a both and. So there's lots of advantages, we know, to partnership working, and partnership working that really does start with people. I lose count of the times that I sit in meetings where people are never, ever mentioned because all we do is talk about money and metrics. We really need to centre this on people. And we need to really think about how we do that with humility and kindness from all sides. And it does need brave, courageous leadership, but leadership that recognises that those leaders don't experience the lives of the communities that they're leading. Yeah. We really do need to ensure people have the time, as Gillian described and what they've done in Surrey. People need time to just be in communities, to spend time deeply listening and recognising their own prejudices, recognising their own biases, because we all have them. And then we have the 10 principles that we've set out in statutory guidance. For the first time, it's statutory guidance that covers all the duties to involve, both on integrated care boards, foundation trusts and trusts, and local government association are recommending it as good practice for local governments. We did co-produce it with an awful lot of people. I don't ever recommend co-producing anything with that amount of people. However, it is only as good as it is because of the contributions that all those people made from their experience and their lived experience. So these images will be available on the NHS England website as soon as we've had the final tweaks made to them. I could say an awful lot more, but I don't have time. But yeah, I'm really happy. I'll stick my Twitter handle in the chat, and I'm really happy to take any questions.
Thank you so much, Olivia. That was excellent. I was just looking at one of the questions in the chat box, which is from Liliana Risi, and she says, how do we set the conditions for leaders to be courageous? And I just wondered whether you thought the 10 principles and the sort of legals around that and the assessment framework that I know you're developing, is going to be the lever to do that, or along with all the other elements that you mentioned, the challenging biases, et cetera.
Yeah, so some of those conditions are that people are scared. So if anybody's ever been involved working for the NHS in a major service reconfiguration, they get shouted at, they are abused. It's horrific. So we have to work to create an environment where leaders of all varieties, be they a leader in their own work, be they a leader of a system, are not afraid to connect into communities. But we have a lot of fear. NHS staff, local government staff experience an awful lot of really quite appalling behaviours.
Yes.
So is it then surprising that they really don't want to engage? They are scared. So it isn't up to any statutory guidance or any one organisation to create the conditions. That's about us as human beings creating the conditions for all of us to be able to connect and engage with one another. And no statutory guidance, no OD programme is ever going to do that until we take responsibility for that for ourselves.
Okay, thank you. Thank you very much. At this point, I'm going to hand over to my colleague, David Siegel, Associate Director from PPL, who will facilitate the panel discussion with our panel members. So, and remember, we're trying to distill a number of calls to action, one or more. So, so thank you, David.
Thank you, Marion, and afternoon, everyone. Lovely to meet you. As Marion said, I'm from PPL. We're a social enterprise in B Corp that exists to promote better health, wellbeing and economic outcomes across the UK. We do that working with individuals, communities, and of course, the organisations that support them. Many of you around the table today. So I invite everyone to sort of really reflect on things you've heard today. And if you could put up any questions into the chat now, or start doing that, that would be great for any of our panel members, or indeed Olivia as well, and we'll try and get through some of those. I know there were some hands that went up earlier. To start us off, I will ask a couple of questions myself that have popped up as we've started talking through, and I think we'll start with one for everyone, which is, what is the one key change that you think would create a shift of power that would enable ground up health creation that we've started talking about today? So Kirit, I'll start with you if that's okay. To give your sense of what would be that one key change that we need to take forward to enable health creation?
I think one is about how do we get coaching and mentoring in the system. So if you've got a somebody in a leadership role, they should have somebody from a lived experience to work, mentor them and coach them, be coached by them. That would help to kind of start to get lived experience on the agenda. It's happening, but it's not happening everywhere.
Thank you, Kirit. And the same question to Jill.
Thank you. I think what I've seen in our system is just that listening and enabling at every stage of the system. So it's not the top of the system trying to control the level below, all the way down to the neighbourhoods. It's a complete inversion of that. So everybody is trying to listen and shift power towards that ground up community-led change. That's what I've seen that's been helpful for us.
Fantastic, thank you, Jill. Mike.
I'm going to try and be a bit more Donna, I think, and encourage the radicalness. Yeah, we've seen today, haven't we? The NHS is going to be facing the biggest financial squeeze since the 1950s. Make no mistake, local councils, particularly in the northern part of this country, I think are teetering on the edge of financial sustainability. Either we continue to try and chase down the elective recovery list as if it's the only thing and for our A&E target, or we try and have a very, very different approach and give some of that responsibility that we all hold to the communities and let them self-organise, and be quite clear that they will do the right thing if we trust them, and if we can get past the mindset of thinking that statutory agencies know best. Too much of what I see is agencies holding on to power, and it's not powerful if you keep hold of it. It's only powerful if you give it away. And communities, in my view, often have the solutions for themselves. We just need to be brave enough to give it to them and step back and coach and encourage and mentor and support. So that would be my kind of big wish.
Thanks, Mike. And Donna, I know you put out the challenge to us very well before. What would sort of be the one practical change that you would see that starts us on that journey that you talked to?
I think I'd start with this obsession with governance structures that we have in the ICSs at the moment. And, you know, putting Health Watch on a committee does not mean that you've involved the community. You know, for God's sake.
Yeah. Oh, yes, you echo my thoughts.
So I hope that's resonating with people. You know, that is not the community. And, you know, we've got to stop leaders thinking that because they've set up a structure, that's job done, tick. And because they've written a strategy which talks about communities, but they don't engage with them. Like Olivia said, you know, use Olivia's tools. You've got them there. Stop looking up to the NHS for the rules, you know, and following that kind of factory model that was created in the 1940s that is no longer fit for purpose, and start to look outwards to communities for the answers.
Thank you, Donna. And being an organisation that helps with some of these things with colleagues around the table at lots of different levels, we know that governance is an important part of the picture, but the amount of times we are asked to start there first, and that's completely back to front. We've always known that we should be thinking about what we're trying to do before we put the structures in place, and yet we still do find ourselves starting with that. So I would completely agree with that. And Olivia, again, I know you sort of just talked us through sort of where NHS England is, but what would you like to see in terms of that one change out in the systems, I guess, rather than centrally?
I think it's about space for honesty, because we can't do everything we want to do. There is a really tight financial environment. Communities can't do without some resource. General practice is falling over and is on its knees. A&E is falling over and on its knees. And we need skilled people to be able to create spaces for conversations with kindness, to host everybody together, not just communities here, professionals here, system leaders here. We need space for people to come together to have those really honest conversations about what is the art of the possible. And as Donna said, without creating some ginormous governance structure that looks great on paper and is utterly meaningful in practice.
Thanks very much, Olivia.
Can I just mention, so there's, I did put in the chat about, we did a session on trauma-informed care and communication last week with a psychologist who's truly amazing called John Connolly, who provides care in a homeless service in London. There is a recording of that, but we're also going to work with John to set up and deliver a whole series of sessions with him. So please do, you can get in touch with us and then you'll get the updates directly. But the recording of that one's on our Future NHS space.
Great, thank you for the reference, and I'm sure that lots of people would be interested in.
Because actually, sorry, trauma and understanding trauma is something we all need to get our heads around, because communities are traumatized, staff have been traumatized, people live with really complex trauma, and then they usually gain a label, a bit personality disorder. How insulting is that? We need to really recognize that people are traumatized, and we don't recognize that, then we blame them for not coming to their appointment, or we blame them for being angry, when actually it's a reaction to trauma.
Thank you. Great, so I'm going to come to some questions in the chat. I've seen at least one pop up. My colleague Rachel is going to help us with that. So Rachel, would you be able to pick up any questions that have come in the chat?
So there was one from Tamara, which I think is for you, David, to PPL. And then there was one from Jane for Gillian. which was how did you identify who to visit and how did you kick off the conversations with Growing Health together?
Great. Well, I'll do the PPL bit very quickly. So I think I started introducing us at the beginning, but in terms of what we do, we have come from sort of management consulting transformation background, but we are a social enterprise and a social enterprise model. So slightly different to other consultancies, at least we hope so. So if you do need to learn more about us, our website is ppl.org.uk. Jill, let's come to you on the question.
Yeah, thank you. I was just trying to type an answer actually when Rachel read that out, so I'm very happy to speak it instead. It's really interesting. Our approach kind of changed. So we started off for me, it was in the consulting room, listening to what patients just kept telling me was making them sick, and we knew what was needed for them to be healthy, but we weren't going out there to actually correct what needed to be changed in the local area. We were just trying to push pills to treat the consequences of the poor environment. So that was the first thing, actually listening in the consultation, really listening to what my patients were telling me. And then the second stage was actually meeting all the head teachers of our local town with another couple of health professionals, nurses and doctors. And it was just amazing. We were all dealing with the same issues, you know, we were dealing with the same population. Of course, this was just showing up in slightly different ways in the schools and the surgeries. And then the third thing was we held a community event and invited a bunch of people. And that was really great as a start. But then COVID hit and we couldn't do big kind of things anymore. So we did it much smaller. And so we weren't targeting particular individuals. We were literally spending time in neighbourhoods. So whether that's community centres, food banks, on the high street, in the library, you know, wherever people are, we're there. We're not, you know, no set agenda, no set opening of the conversation. It's just showing up as a person, you know, how's it going? What's happening? And then through that process, just remarkable things would happen. And then you'd get lots of introductions. So, oh, you must meet this person. They want to meet you. They want some support with something. And then beautiful things kind of grow out of that. We've recognised that in Surrey Heartlands, there are huge health inequalities, despite being considered as a very green, leafy, affluent area. And we're now that we've kind of come out slightly of COVID, we're now trying to be more proactive in certain areas. So we're doing more intensive health creation listening work on a particular housing estate in Merstham, for example, where lots of different people from different institutions, the police, fire service, teachers and health have had health creation training and are having more health creation training so that when they're engaging with those communities, they're really doing it in a truly health creating, enabling way. So that will be a little bit more structured. But yeah, that's some of the approaches that we've used. It's kind of a mosaic of different approaches, I'd say.
Thanks, Jill, and really great examples there. And I'm sure people want to learn more, you'd be happy to connect them in some of that work. Before we come back to the chat, if there's any further questions, I will ask a quick question to Mike, if that's okay. And then if other members of the panel would like to add in anything, please do put your hands up. But we obviously heard a number of really great things going on in Oldham and indeed from other panel members around health creation. But why do you think, Mike, that this hasn't become the norm, and initiatives to support health creation haven't become the norm, given the value that we've seen from some of the initiatives, both in Oldham and elsewhere?
I think there's more of a movement in Greater Manchester. I think the devolution agenda has allowed us to think, to be more creative, to think a little bit differently, but crucially, I think this is probably the key bit, to join up the NHS with local government. You know, I think I made reference to 80,000 conversations. We knocked on 41,000 doors. I knew exactly which house people had not been vaccinated and which people in which houses had not been vaccinated, because we were able to look at the GP registers and the local authority data all in one single place. You know, from there, I think it's back down to Olivia's point about courageous conversations. We spent an awful lot of time training people to have courageous conversations, working with imams in mosques, asking them what would land, what wouldn't land. In fact, asking them if they would like to do it and get involved with it rather than just us doing it, and done it together. Our approach is very much, I think our preference is very much to look at the data and try and use the data to find the kind of questions that we need to go and ask, and then you're not going to find the answers in the data alone. So for me, I think joining the NHS with local government is a start. I think it gives you a much richer, clearer picture. I'm in Donna's space. Simply creating a board and a committee and putting people on it is not going to achieve it. That's an important thing for people to understand progress. But you've got to push it out of there and into the communities and get the communities to do it. And then, I think kind of keep a watchful eye on what's going on and intervene where you need to, step away where you need to as well at the same time. But without the intelligence of local government, I think the NHS is swimming in the sea of mist, I would suggest. And that's why I say, if all we're going to do is get sucked into a vortex of looking at elective recovery and A&E times, we're not going to be tackling the problems that are affecting communities. That's a tiny, tiny fragment of communities that touch those type of spaces. So for me, local government and GM has been at it for 5 or 6 years, and it doesn't have all the answers by any stretch of the imagination. I don't think it's radical enough, but it's probably got further than some places. Thank you.
Thanks, Mike. That's great. Definitely a few questions in the chat. So Rachel, should we take, if we can take 3, if you could read out 3 key ones, and we'll ask panel members to pick the ones they want to answer.
Sure. So there's an interesting one from Asmina, who said that they feel that governance or confidentiality always comes in the way when engaging with statutory organisations, and are a majority of meetings confidential, and what impact does that have? And then there's one from Mary about what can businesses in an area do to contribute to health creation? So how can businesses facilitate community connectedness and good health for employees? And then there was one from Jane about, are there any health visitors? Because older members of our community often ask for the health visitor, but are there actually any working in the UK at the moment?
Great. So let's start with the point around confidentiality and the way that sometimes prevents engagement with communities and residents, people we support. Does anyone on the panel want to take that one? If you could, Mike, perfect, thank you.
So these are I think some of the most important people for the wrong reasons. I think if you let information governance people find ways for something not to happen, they generally will, because they're geared to protect their organisations. We need leaders to actually be brave and actually enable changes to be made. I think most people in our communities expect that the NHS and local government work together, expect that there is no difference on the data, and expect that they have one picture of everything that's going on. What they don't expect is to tell the story 5 and 6 times every single time they touch the system. So for me, I don't believe there's any legislation that stops us from sharing data. If there is, I haven't found it. I think we find all kinds of organisational rules and barriers that are convenient, and I think we need to be braver in making it happen.
Thanks, Mike. Kirit.
Just a quick add. What I do is I actually get my information from attending, going on the podcast for the Scrutiny Health Commission and the Health and Wellbeing Board meetings, because you'll find information that when you try and get, you don't get it. So it's always a tip, as Mina is, you can go on those public meetings. You may not be able to speak, but you will get the information. So I would do that as one way. And as Mike said, the data is there, and obviously ONS have got some up-to-date data. We work closely with our public health to get the data to help them with the vaccination agenda as well.
Thank you, Kieran. I think my mind comes back to Olivia's point that we need to use all of the things that are available to us in terms of not just how we engage, but how we create connections in spite of some of the challenges that might be seem initially impossible to overcome in terms of governance confidentiality. So thank you for some very practical points around that. If we go to the next point around what can businesses do in health creation, because we have talked today mainly about people working within services, health and care services. Donna.
Yeah, I think if you are employing an asset-based community development approach, as Olivia and I totally agree with that approach, then businesses in a local area are assets. And I think one practical example from Wigan was we piloted our integrated neighbourhood team in a place called Plattbridge, or Platt Vegas as it's commonly known. There's not many assets in Plattbridge apart from the people, a doctor's surgery and McDonald's and a Betfred. So, and a pie shop, we use those assets to work together. And the McDonald's in particular, you would think, oh, they're not very healthy eating, it's not great to encourage people to go there, but lots of young people, there's lots of antisocial behaviour in and around that restaurant in an evening, and not much for young people to do. The franchisee of that facility was he was a care experienced young person, and he was passionate about things for young people to do. So he set up with his staff and with the local community a brilliant out of school activity group around the restaurant, not encouraging people to go into the restaurant, but he deployed an AstroTurf, what do you call it, a mugger, multi-use games area that was right next door to the restaurant, and they worked together, and that's still going now. So, you know, businesses in local areas want to help the local community. They are a source of intelligence and information about what's really going on.
Thanks, Donna, that's great. Olivia.
Yeah, if I can just jump in, if you're working in a local neighbourhood and you're not talking to your local businesses, I'd question whether you're working with your local community, because they're people who live in the communities, particularly local businesses. But one very brief story, and if you Google the Shrewsbury Arc or the Prince Rupert Hotel in Shrewsbury, Mike, who owns the Prince Rupert Hotel, was contacted by the Shrewsbury Arc. He's the Conservative leader of their business and community scheme. He will self-confess he's the person who walked over people sleeping in doorways and judged them. And during the beginning of the first pandemic, the first wave of the pandemic and the really strict lockdown, he opened up his hotel and he moved into his hotel with his hotel manager, Charlie. And they had, I think, about 16 people who would have been on the streets otherwise. And they formed a social bubble when we had bubbles. And he learned more during that time. He left his family for the duration, as did Charlie. It was a real investment. They didn't have any appalling behaviours or anything else. If few people had alcohol addictions, and actually their answer was, well, you can get a shot of vodka at reception if that's what you need to keep you safe. Most of the people who went and stayed with Mike in his hotel are now working in their own accommodation. Some of them are working for him. Some of them are working for people that he knows through the business and the community networks. I think we must never judge a book by its cover. Because he's the least likely, and he will self-confess this if you chat to him, he's the least likely person to have been that man, and he was that man, and he feels like he's a better person as a result of that. So I think there is something about, yeah, I mean, as a community development worker by background, local businesses were always our best partners because they care. They care about antisocial behaviour. They care about having their stuff tea leaf from their shops, and they want their neighbourhoods to be happy, healthy, thriving neighbourhoods. So don't forget about them just because you think they might be making a profit. Profit is not a bad word. Profit is quite healthy because profit enables us to reinvest.
Thank you, Olivia. Really helpful. And then the last one, which is a practical one around some of the people and patients that are supported, often referring to health visitor models as a model they miss. Are the panel aware of any models that are either the same or very similar to those health visitor models, or any reflections on the way in which a sort of more personalised model, I think is probably being referred to, might see a comeback in our health and care services, given the difficult climate that we're living through?
So I think I'm going to jump in. I think this goes back to local systems at neighbourhood level can take control and do this. Focus care in Oldham that Mike referred to, it is amazing. It's been going for years. If you've got any doubts that it's the way to work, read their evaluation reports, read the difference that they've made in terms of really addressing health inequalities. This is all possible. But it takes people to leave their egos at the door, stop competing over territory, and really start to collaborate and be greater than the sum of their parts. I don't care if you work for the NHS, local government, the voluntary sector, a community organisation. It's your responsibility to be truly collaborative and stop gatekeeping, because all these things are possible. So there are other models similar to focus care elsewhere in the country. Health visitors do still exist. They are completely overwhelmed because the level of safeguarding risk has escalated over recent years. And health visiting for older people tends to now be seen as something that district nurses do. So health visiting does tend to focus on the 0 to 5s and children and families with safeguarding challenges. But again, it's another service area that needs to really think about how it starts with people and really is led by people as opposed to trying to fix people.
Thanks, Olivia. And Jill, don't know whether in terms of, well, the numerous hats that you wear, both as local GP, but also the work you do in the neighbourhoods, do you have any reflections around sort of the way in which certain models might move forward in the future?
I'm not sure I can exactly answer that question, but of course I agree with everything people have said about how key health visitors are. My goodness, we need more health visitors, right? And health visitors are absolutely key as part of our integrated neighbourhood teams at each of the PCN levels. We regularly, with members of our community, the faith groups, the charities, and also the health visitors, so that they know, and the district nurses and the matrons know about all the amazing things happening in our communities and can actually share that with the people that they're interacting with. So yeah, thank you.
Thanks, Jill. I think we've got time for one last question before I'm going to hand over to Donna to give us a short intro into both some of the community power work and indeed ahead of our breakout. But Rachel, is there any final question from the chat?
Yeah, there was one question from Tom saying, I can recognise the benefits of health creation in many areas of health, but what about in mental health? I'm not convinced that better collaboration in itself will overcome the abuse and systemic failings in mental health. What do you think?
A very big question to end on. Does anyone from our panel want to go first on that? Jill?
I think that there are two things that need to happen. Clearly, there are things that need to change in the mental health system, and more investment is clearly needed. But there's also so much that can be done through health creation right now. Every day I'm emailed stories about people who were feeling suicidal and absolutely desperate. And yet through connecting with their communities and finding that sense of belonging and meaning and purpose, their mental well-being, mental health has been transformed really rapidly, so much more rapidly than anything I could do as a GP. Of course, we need really good mental health services for people who have got severe mental health problems, but there is a lot that we can do through health creation as well.
Great, thank you, Jill. I think that's a good point for us to bring that Q&A to an end. And then we're going to hand over to Donna. And so Donna, with your new local hat on, I guess in this example, to hear your views on how community power both connects with and is an important part of health creation. And really ahead of our breakout session to crystallise a bit of a call to action for all of us of how we might take forward both community power and health creation. So over to you, Donna.
That's great. Thanks, David. Is it okay if I just spend a few moments just explaining a little bit about Wigan as well, just to give, so that people don't think I'm some crackpot academic just coming in talking about community power without a context for it. Basically in Wigan, we created this thing called the Wigan Deal that Merrin referenced right at the beginning of the session. And if people are interested in finding out a little bit more about it, the King's Fund did a really good evaluation of it couple of years back, and maybe someone can post that in the chat whilst I'm speaking. It was lessons learned from the Wigan Deal, and it was really helpful around what we did, how we did it, and what difference it made. And they came to live with us for a year, the King's Fund. So it wasn't just a flash in the pan thing. They actually did speak to citizens and they did speak to staff, and that's where they got their stories from. So what they said about it was, and we added an additional 7 years of healthy life expectancy to people living in the most deprived parts of the borough. So it was I'm right in the middle of austerity. So, and it wasn't us that did it. It wasn't public services that did it. It was the community that did it. We invested around 13 million. We didn't have a top-down commissioning person who said, right, this is what we need, and designed it without in a completely darkened room. We asked local people what they wanted and what they felt was needed in the local area. So whether it was a rugby memories group to support people with dementia, whether it was mental health project for young people, designed by young people, sexual health services, gypsy and traveller services that were just you know, really rubbish, like top-down commissioned things that we'd never actually spoken to the people on the receiving end of these services. So instead, the sector, the community and voluntary sector created this thing, the community created this thing called a deal, and it had a huge impact. It's still having a huge impact. What we're seeing, I think, now at the moment with the changes in political leadership in the government is one day we have a new strategy, the next day it's gone. We get a new person comes in with a different mindset. That's why if it's created by local people and it's about a place, it doesn't change, it stays. And that's why the deal is still going on today, because it was created in a place by people. And that's the kind of long-term strategy that I think we need in the NHS and in local government and in integrated care systems. So I chair a think tank. I'm not trying to sell this think tank. I don't get paid to do this job of chairing the think tank. I just really love it. I think they do a great job. Been going for around 30 years, an organisation called New Local. They work across the NHS and we've got around 75 members. Some NHS organisations and some councils, mainly councils, but you're welcome to, if you just look at newlocal.org, you'll see all the details around how you can get involved. 3 years ago, we wrote a report that was quite seminal, really, and it attracted a lot of attention from local people and from national politicians of all political colours. It was called the Community Paradigm. Again, if you're interested in it, I'm sure some person cleverer than me can post a link to the Community Paradigm work. Written by, not by me, but by our fantastic Chief Exec, Dr. Adam Lent, and Jess Studdert, the Deputy Chief Exec. And what we argued really was for a complete change in the way that public services are managed. So basically, when the welfare state was created back in the 1940s, thank goodness the welfare state was created with the Beveridge Report, it was a very different world. And yet we've not fundamentally changed the model of public services since the 1940s. So this whole idea of a state paradigm created in the 1940s, where it's designed around the factory model with basically one size fits all. It's not sensitive to local communities. It's not co-designed. It's just there. It's standardized. It's transactional. You are processed through a system like you're on a conveyor belt. It's a centrally planned funding model. Accountability is to Whitehall, not to local citizens. It's all about quantitative data and decision making from the top, disseminated out to local areas. It's very much about individual specialist organisations doing you a favour by helping you. You know, that's the kind of structure of the state and and not just the NHS, but local government as well. Then in the 80s, those are old enough, including myself, to remember, will remember this, but the market paradigm was created with Margaret Thatcher selling council housing, the creation of the Lansley reforms, where there was a separation between the procurement and the commissioning of services, the creation of a marketplace within the NHS, which in my personal view was a complete and utter disaster, where it's all about efficiency. It's all about the private sector knows better. We set up boards to run hospitals because we thought that business-driven model of a board was the way to do it. It's all about treating illness more efficiently, transactional again, customer-focused rather than citizen-focused, all about performance targets, you know, red, amber, green, key KPIs, competition between different organisations so that people don't work together in a place. They're actually, and we've seen this, Mike, in Greater Manchester, haven't we, where hospitals are actually sometimes in competition with each other. You know, who's the biggest and the best and the biggest beast. And this thing about ego that Olivia said, I can't overstate that. That is so prevalent within both the local government and NHS world. It's almost like a celebrity, it's almost like, you know, a celebrity culture around senior people within these organisations. It's a very much an activity-based funding model. So hospitals get paid depending on how many operations they do. So you get stupid situations like in Wigan, where I was from, where in terms of, so orthopaedic centre of excellence, you can get your knee replaced within 2 weeks if your GP refers you to write it to Wigan and Lee. But if your child's got mental health issues, you're waiting a year to be seen. So there's nothing, it's not based on need, it's based on activity. And again, very quantitative. So we've wanted to move away from this state paradigm, central top-down, market paradigm, outsourced, privatised, to a community paradigm, which is very much around prevention. So rather than focusing on standardization and efficiency, it's around preventing ill health and creating health, which is what the Health Creation Alliance is set up to do. It's very much about clinician working with community, working within the local community. It's asset-led, based on the local assets in the local area. It's collaborative. It's based on culture shift. It's based on the deep listening that Olivia and others have mentioned. It's place-based. It should be around everyone working together in the place with local citizens to promote good health. And it's about communities. It's reaching out. It's a partnership. It's not about us doing things to people. It's about equality and about trust within local communities. Quantitative data is part of it, but qualitative data is really important. What did that service feel like to you? How did you feel like when you accessed that service? And how can we create, as Olivia said, how can we try to help you have a good life? That's what we should be doing. That's what we should be aspiring to do, not just ticking off a KPI. We had a gentleman in Wrightington, Wigan and Lee who had accessed our A&E services every single day for a year. But because we'd hit the 4-hour wait target for him, he wasn't on anybody's radar. Nobody reached out to help him in any way. It was, tick box culture. We've got to throw that away. We've got to throw that whole mindset away. And that's where we need the courage, because we're very much down the lines of those previous, either the state or the market paradigm, with quantitative data and, a real shrugging off of responsibility. And I'm a bit worried about some of the ICSs I've been speaking to, and a bit of a kind of, we're here to manage that status quo. That's our job. Management of status quo, get through winter, keep everyone safe. It's just not possible. And in 4 or 5 years' time, it will be completely impossible. So let's be bold, let's be radical. Let's shift that paradigm towards a community one. I hope that's okay.
Thank you, Donna. And we are going to be going into breakout groups in just a moment. I just sort of heard a snippet there where you said that's what the Health Creation Alliance is set up to do, to create health. Well, we're actually pointing to where health creation is already happening, because it's happening everywhere. We haven't invented it, it's happening all over. And all we're really doing is trying to join up those people doing it so that we can be stronger together and create that movement to enable it and to raise the status and profile of it. But we're also interested in hard measures to make it happen, to knock those ICSs off their complacency and push them into a zone where there are consequences if you don't do it. And that's partly what this event is about, and this series of events. We're not trying to be harsh or forceful, but at the end of the day, how can we be radical? How can we create those conditions, as Lily said, for leaders to be courageous, but also perhaps radically kind, and for that to be rewarded, and for that to, for the alternative, for the opposite, for complacency, to be actually, not continue in the long term. So I think we've just got so much from this session, and thank you all so much for your contributions through it, and including, I'll just quickly go back through the what one thing at the beginning of the panel session. Kirit mentioned a system of mentoring might be one part of the solution here. Gillian, radical listening and responding. It's the responding that we often get wrong. We don't do it, we don't follow through. How can we make that time and put that in to respond, because that's what builds the trust. Encourage radicalness, I think was Mike's point, and not just the setting up of the structures. There's a lot of thoughts here, and Olivia, with your bias, points as well, and radical kindness, and how can this have teeth going forward? It's difficult, isn't it? But we'd love to be able to find some of these harder levers that will help to push in that direction. So I'm not going to say any more. We're going to go into breakout groups. We're looking to firm up one or more calls to action within those groups. So do stay on and contribute to those conversations. And Neil is now going to, there's more questions come out of this than in those two. So do follow up some of those questions. But we'll we'll have a quick 5 minutes at the end feedback on those. So Neil, breakout rooms. Hello, Neil.
Yeah, sorry, I just need to take myself off on mute. Marion, can you just clarify, just so it's very clear for everyone, what it is that we're asking them to address in the breakout rooms?
Sure. So there's two questions here. The second one is probably the easiest. What will you do personally to adopt and embed health creation and support ground up transformation in your system, whatever your role, wherever you are in the system? That's the movement. How can you be an agent of change? And what do you think of the proposed calls to action? Now, you know, there's a number that I've just mentioned, really. Are they realistic? How would you like, you know, which do you think is the most important? And so just focus on those two things. What can you personally do? And what about the calls to action? What harder levers might there be to achieve some of this? And David's team at PPL, David, do you just want to remind us who are going to facilitate so that Neil can put them in the right groups?
Oh, there, I've got them in all of the right groups.
Oh, you've got them. All right,
yeah.
Great.
Okay, so just in case anyone's not used Zoom meetings before, so what I'll do is I'll just hit the button and you will all automatically go into a particular room, and then following that, after 15 minutes, you'll have a 5-minute notice before being called back into the main room. So I'm just going to put you into rooms. You'll just need to then accept the little button that you're going into the breakout rooms.
Hello, is everyone back? Looks like it. Great. So, well, thank you. We could have gone on for a bit longer, but and I'm sure some other groups could as well. But what we're going to do now is to have a little bit of feedback on the on how you got on with these questions. Just we've got 5 minutes for this only. So I think there were probably 4 groups. That's like just over a minute per group. So I'm not going to say who. Well, actually, Rachel, do you want to start?
Sure, happy to start. And if I miss things which my group do chip in, we talked a lot about the power of informed practice and training as something to help shift how the NHS have conversations about the issues we spoke about in this session. We talked about the role of love in this and having your work showing love to communities and self-love in the way that you interact with communities as well. We talked about the importance of having a small, passionate group of people who can lead a shift towards health creation, but also the importance of everybody doing their bit. And if everybody were to change one thing, that would have an enormous impact. I think I was going to summarize what was quite a lot of depth in 10 minutes. That's what I would summarize.
Thank you. Who wants to go next? Just start.
Yeah, I'm happy to summarize from our group. Again, great conversation, and correct me if I've got anything wrong, people in group 1. I think 2 key things came out. There was something around very much everyone agreeing with the call to action, but when we're talking about the kind of community paradigm and the moving to that movement, we need to attach it from a kind of pincer movement. We said one is having the leaders at the top who buy into this and will support and drive it forward. And the second thing was for people more involved in engagement communities or delivering services, there actually needs to be training and development around this kind of approach to enable people there to better deliver it on the ground. So that was one key thing. And there was a second piece about getting communities involved from the start. So often there was a lot of discussion around people's priorities and communities not necessarily matching the priorities of the organisations that they are that are delivering things for them. And so getting those things aligned from the start and really building on that community engagement up front. So building on, I think, Donna's point around if it's people who help own and define the change, it's much more likely to stick around. So I think those were 2 main things that came out, as well as a lot of other stuff in our conversation. Thank you, everyone.
Wow, so different things. Excellent. Who would like to go next?
I'm happy to feedback from our group. So we had a really interesting conversation where I think we agreed that there's a need to change things because the system at the moment is broken, and sort of there are real issues around trust with people and communities in terms of professionals. We also had a really interesting conversation about whether it's about changing model or changing purpose, and actually sort of a view that you can't change the model without changing purpose. And the other thing we wondered about was about how do we sort of campaign to get this on people's radars? So is there a sort of health creation covenant, and sort of how does that also feed into some of the sort of political commitments of the parties?
Thank you, Russell. I noticed a question in the box earlier. Is there a health creation manifesto we could have? Well, there is one, but it's a bit old now, and we do need a new one. So maybe that's a role, maybe for next year, a covenant. I like that. Okay, so lots of different things coming out. And then David, do you want to feedback for?
Yes, so I'll, I think resonated with lots of conversation we had. I guess to start with the positive, we do think that the calls to action were realistic, but also need to be clear that there are other things across formal health and care system that need to be sorted that won't be created by sorted by health creation necessarily. So if we don't sort things like A&E waits, if we don't sort the problem with planned care backlogs, if we don't sort some of the systematic cruelty that we've seen in some of the provision of care, particularly in cases recently, but we know that they are not the first, then health creation won't be able to deliver on all the things that it promises. So it's really important. We also need to do those other things. In terms of sort of call to action personally, we had some really good conversations about the need for everyone to be brave and courageous throughout the system, leaders of all sorts. But we also talked about the fact that that's difficult and often very risky. So clinicians, professionals, community workers are often the people that suffer some of the biggest risk themselves in their roles, will suffer harassment of other sorts or negative effects from residents and patients because they are on the front line. So how do we create an environment where actually being courageous is much easier, that the risk of doing so is shared, and that people are genuinely supported in moving health creation forward? So there's a sort of call to action both ways in that sense.
Thank you. And has anyone from the groups got anything burning that they discussed in their group that hasn't been said before we say goodbye? No, great. Okay, well, I feel like that's been really rich. And I've just realised there's another whole screen full of people here, but no one put their hand up. So it feels like it's been really rich, full of, new things, new ideas, maybe not new to all of us, but I'm sure we've all learned something from all of that. And there's lots to go on there. So thank you so much for that. And it just leaves to me to say thank you so much to our speakers, to Kirit, to Jill, to Mike, to Donna, to Olivia, and I don't think I've missed anyone, but thank you all in case I have. And thank you so much to PPL for sponsoring this series of sessions, and particularly for helping with the facilitation of this session, and colleagues there. So thanks to all our sponsors, including National Health Executive and Public Sector Executive, HLM Architects, NHS Property Services, Novartis, PPL, Solace, NHS South Central West, and our patron, Lord Victor Adeboali, and Lord Nigel Crisp, who provides that umbrella for health creation so well. And they'll be appearing in our final session on Thursday afternoon. They'll be chairing and leading that session. So thank you all as well for your interest and time spent, with us here today, connecting on this theme. It's blown my mind, actually. I'm just so pleased, how well it's gone. So thank you. And if you haven't already joined the Health Creation Alliance, please do that. Thank you for completing that evaluation as you log off. We need that because we need to put a case together for funders to say, please, can you enable us to continue and to grow this work. And please do book on other sessions that are still to come. Neil will love you for that, because every time anyone books now, he has to send you an email individually. So thank you, Neil, for that. And hopefully we can start this call to action emerging from, these call to actions emerging from this session. There's been a lot to go on today. So thank you very much, and goodbye, and see you again later in the week, perhaps. Thank you.
Bye.